Welcome to The Code Tray, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
First, we'll have Mallory Schwartz, who is a PGY1 resident at the University of Cincinnati Medical Center, and she will be presenting a journal club on IV Tenecteplase prior to endovascular treatment for ischemic stroke at 4.5 to 24 hours.
To give some background on this, so first, just defining what endovascular treatment is, and this I will be calling this EVT for the rest of the presentation. It is a standard of care for eligible large vessel occlusion strokes up to 24 hours in selected patients. Benefit of thrombolysis prior to EVT remains controversial, as we have multiple studies that have come out and kind of not shown us maybe if we should be doing it or not. And looking at TNK in general, so Tenecteplase, I will also be referring to that as TNK going forward. It is a single IV bolus administration, has greater fibrinogen specificity, and has a longer half-life compared to alteplase. So some benefits of using Tenecteplase over alteplase. Some prior studies, so 3 important studies that set the stage for TNK-PLUS, which is the study. Bridge TNK evaluated TNK before EVT in patients presenting within 4.5 hours and demonstrated improved functional independence compared to with EVT alone. TRACE 3 evaluated patients presenting 4.5 to 24 hours after stroke onset who did not undergo EVT and found improved functional outcomes with TNK. However, the Timeless study evaluated TNK before EVT in the later window, so 4.5 to 24 hours, and failed to show a significant overall benefit. But interesting enough, there was a subgroup analysis of the M1 subgroup that showed a potential benefit signal. So because of these findings, an uncertainty remains regarding whether TNK may be beneficial and may be more carefully selected in those patients in the late window. So our current guidelines are the 2026 AHA guidelines recommend EVT up to 24 hours in approximately selected patients. For patients presenting within 4.5 hours, TNK or alteplase is recommended when eligible, and for patients presenting between 4.5 and 24 hours who cannot undergo EVT, thrombolysis may be still beneficial. However, there is no current recommendation for patients' routine TNK administration before EVT and patients presenting in that late window. So that leads us to why this study. So although Timeless was a negative overall result for TNK before EVT, there was that select subgroup that I talked about, the M1 subgroup, suggested that a possible overall benefit. And therefore, investigators really just wanted to dive deeper into that and whether TNK before EVT could improve outcomes specifically in patients with proximal MCA, which occlusions presenting in the late window. And so really just diving in more deeply, and that led us to this TNK-PLUS research question. So does IV TNK administered prior to EVT improve functional outcomes in patients presenting 4.5 to 24 hours after ischemic stroke onset due to proximal MCA occlusion? So the objective of the study was to investigate the adverse events and efficacy of Tenecteplase prior to EVT in patients 4.5 to 24 hours after ischemic stroke onset due to proximal middle cerebral artery or MCA occlusion. The study design, so this was a multi-center, prospective, randomized, open-label, blinded endpoint. It was a superiority trial, and it was conducted at 4 centers located in China between January 2024 and July of 2025. And at all of those centers, it was IRB approved as well. Here are just some of the study definitions. So EVT or endovascular treatment was defined as minimal invasive surgical procedure used to treat AIS, which included stent retriever, aspiration, balloon angioplasty, or it could be a mixture of both of these. The modified Rankin score was used to measure the neurological recovery of the patient. So this can range from 0 to 6. And then we have the NIHSS scale, which is the National Institutes of Health stroke scale, which can be assess the severity of the stroke. And this ranges from 0 to 42. In particular, I like to pull up this visual just to understand what the modified Rankin score actually means. And so it actually measures the disability after stroke. And so a score of 0 really just means no symptoms. A score of 1 means that maybe the patient has minor symptoms without disability, and 2 indicates more of that slightly disability but continued independence. And so for this study, they do focus on from 0 to 2 as their primary endpoint. So just something of note. So leading into our primary endpoint, so outcomes, our primary outcome was functional independence at 90 days, with secondary outcomes including overall MRS distribution, neurological improvement, reperfusion and recannulization outcomes, symptomatic intracranial hemorrhage, and mortality. For inclusion criteria, so this included adults presenting between 4.5 and 24 hours after stroke onset with M1 or proximal, M2 occlusions, favorable perfusion imaging, baseline MRS scores of 2 or less, and NIHSS score between 6 and 25. Exclusion criteria. So this is an extensive exclusion criteria, but I just wanted to name a few of them and go over. So major exclusion criteria included contraindications through thrombolysis, which makes sense, large infarcts involving greater than 1/3 of the MCA territory, multi-vessel occlusions, pregnancy, inability to obtain advanced imaging, or inability to comply with follow-up. Here is a just overall chart on how they randomized the patients. And so a total of 391 patients were randomized, and the primary endpoint was using the intention to treat protocol and population. And so I just have that in the red box at the top. And so in that subgroup, there was 199 randomized to receive TNK before EVT, and then there was 192 randomized to receive EVT alone. The trial design, so it was 391 patients. It was randomized in a 1-to-1 fashion. So 1 to receive TNK with our normal dosing of a maximum of 25 milligrams plus EVT and then EVT alone. The primary outcome was assessed at a 90-day follow-up, and this was the functional independence of the MRS score of 0 to 2. For statistical analysis, so the primary analysis evaluated functional independence at 90 days and was adjusted for age, baseline NIHSS score, and occlusion site. The investigators based their sample size calculations on the findings of the timeless trial, so they wanted to extrapolate to make sure that it was similar results. So they estimated a treatment effect between 10-14% and determined that approximately 390 patients would be appropriate to get a 80% power with using a two-sided alpha of 0.05. For baseline characteristics, overall, the groups were really well balanced, as you can see on this slide. The median age was around 68 years of age in both groups, and approximately 60% of the population were males. Hypertension was present in roughly 2/3 of the patient, diabetes about 20% of the patients, and approximately 15% had atrial fibrillation with a prior stroke as well. So overall, there was really no meaningful baseline differences that we would expect to see any differences in the outcomes. For clinical characteristics, so these patients had moderately severe strokes. Median NIHSS score were 13 to 14, indicating significant neurological deficits at presentation. Approximately 85% had M1 occlusions and 15% had proximal M2 occlusions. The median aspect score were around 8, suggesting relatively favorable imaging profiles with some brain tissue left to salvage. And then nearly 1/3 of the patients had a cardioembolic and approximately 30% were wake-up strokes. For time metrics, so this might be one of the more important slides that we are aware of. And so really, patients underwent revascularization approximately 12 hours after stroke onset. So this was fairly quick in that 4.5 to 24-hour range. And the median door to TNK time was 90 minutes. And most importantly, the median time from TNK administration to arterial puncture was 26 minutes. So this really raises the question of whether that was enough time for the TNK to work on the patient and provide maybe some more perfusion that the thrombectomy would actually give for the patient as well. Primary endpoint of the study, so functional independence at 90 days, was not significant between the two groups. So for TNK plus EVT, it was at 44.2% for that group, while just EVT alone was 43.2%. The adjusted relative risk was 1.01 with a 95 confidence interval, and the confidence interval was between 0.83 to 1.24 with a p-value of 0.89. So therefore, the primary endpoint was not met, and there was essentially no difference between the two groups. It was not significant. When looking across at the secondary outcomes and pulling up the MRS scores at 90 days, it was relatively similar between both groups, as you can see on this slide, and there was really no meaningful shift towards improved outcomes with TNK. Rates were favorable and unfavorable outcomes were very similar between both groups, as you can tell in this picture that the study gave us. None of the secondary outcomes were also significant. So major neurological improvement was 49 in the TNK plus EVT, and EVT alone was 48. NIHSS change at day 7 was also very similar, so 4 and 4. Perfusion prior to EVT was 20 versus 14. Perfusion at 24 hours was 89 and 88. And then recanalization was also at 24 hours was 106 to 96, which is also similar between both groups. For safety outcomes, they were also very similar. Symptomatic intracranial hemorrhage occurred in 5.1% of patients receiving TNK compared to 2.6% receiving EVT. Although numerically higher, the difference was not statistically significant. Mortality at 90 days was also similar between groups at 25 days and 27 days. There is important to note that there was an increase, as we would likely expect, in the TNK plus EVT group in comparison to the EVT group. So for the author's conclusion, the authors concluded that TNK administered before EVT did not improve clinical outcomes in patients presenting 4.5 to 24 hours after stroke onset, and therefore was not supported routine use in this setting. Limitations of the study. So the study was an open label design, conducted exclusively in China, only included M1 and proximal M2 occlusions. However, the most important probably limitation is that it was such a short onset from TNK administration to EVT with only 26 minutes interval between the two. And this could lead to maybe more opportunity for TNK to provide additional benefit with just that short window. And so maybe leading to maybe we should look into if you were needing prolonged time between TNK and EVT, maybe that could be beneficial. And lastly, the study was also not powered for safety outcomes either. And so it was not powered to meet any difference between the safety outcomes. So something to note. Clinical implications. So for centers capable of rapid thrombectomy, which I've discussed multiple times, but these findings likely do not suggest routine TNK administration before EVT in patients presenting at 4.5 to 24 hours after stroke onset. EVT remains the primary intervention for those patients, especially at an EVT center, so thrombectomy center. So could be potentially useful in patients that are not at one of those centers or being transferred to one of those centers. And this is what I've been talking about throughout the presentation, but potential explanations. So both groups underwent rapid and effective EVT. And so EVT alone could potentially provide near maximal perfusion benefit with that short window, and incremental benefit of TNK when limited when timely EVT is available. And so time to EVT was around 12 hours from last known well. And so this could maybe lead us to more questions on whether or not we should be looking at patients that are not at an EVT center. So future direction, so evaluate patients with delayed EVT access, further investigate M1 occlusion subgroups, and potentially have larger studies powered for safety outcomes to see if there were a difference between those safety events or the intracranial hemorrhage. Overall conclusion, so in conclusion, among patients with acute ischemic stroke due to paroxysmal MCA occlusion presenting between 4.5 to 24 hours after symptom onset, TNK administered prior to EVT did not improve functional independence, secondary efficacy outcomes, or mortality. Based on these findings, routine TNK administration before EVT is not supported when rapid thrombectomy is still available. So here are some of my references, and I will take any questions. Thank you, guys.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.